Good morning, everyone. I am Dr. Prasantar Patel, Assistant Professor in Pathology, Government Medical College, Surat. So today I take lecture on storage disorder of infancy and childhood. Learning objectives. At the end of sessions, students are able to enumerate various storage disorders. At the end of sessions, students are able to write pathogenesis of various storage disorders. And at the end of sessions, students are able to write morphological findings of various storage disorders. Lysosomal storage disease. Lysosome contains variety of hydrolytic enzymes that are involved in breakdown of complex substances such as sphingolipid and mucopolysaccharides into soluble end products. These large molecules may be derived from the turnover of intracellular organelles that enter the lysosome by autophagy, or they may be acquired from outside the cells by phagocytosis. Inherited lack of lysosomal enzyme lead to accumulation of the partially degraded insoluble metabolites within the lysosome. Approximately 40 lysosomal diseases have been identified, each resulting from functional absence of specific lysosomal enzyme or proteins involved in their function. Lysosomal storage disorders are divided into broad categories based on biochemical nature of the substrate and accumulated metabolites. Most of the lysosomal storage disorders are autosomal recessive or X-linked recessive, mostly affect the infants and young children. There is storage of insoluble intermediate metabolites in the mononuclear phagocytic systems, which gives rise to hepatosplenomegaly. CNS involvement are frequent due to associated neuronal damage. There are cellular dysfunctions developed due to storage of undigested material and also by the activation of the macrophages, which release cytokines. So this is a table which shows various lysosomal storage disorders like Gaucher disease, Tay-Sachs disease, Sandorf disease, Fabry disease, Crab disease, and Niemann-Pick disease. So these are the important lysosomal storage disorders. Cells of reticuloendothelial cells are frequently involved due to they because they contain high amount of lysosomes in cytoplasm. All these storage diseases are autosomal recessive or X-linked recessive genetic disorders. So this is the diagram which shows how these soluble substances are degraded into normal lysosome. So here in this you can see by help of various enzymes. These substrates are converted into small diffusible end products and ultimately cleared from lysosome by diffusion. Here in this you can see due to absence of lysosomal enzyme, all these substances are not degraded into end products and they are accumulated within the lysosomes, and these lysosomes are ultimately distended and gives rise to lysosomal storage disorder. Gaucher disease. Gaucher disease results from mutation in the gene that encodes glucocerebrosidase. There are three autosomal recessive variants of Gaucher disease result from distinct allelic mutations. There is variably deficient activity of a glucocerebrosidase that normally cleave the glucose residue from ceramide. Deficiency leads to accumulation of the glucocerebroside in the mononuclear phagocytic cells and their transformation into so-called Gaucher cells. So this Gaucher cells is pathognomonic for the Gaucher disease. Normally, the glycolipid derived from the breakdown of senescent red blood cells are sequentially degraded by phagocytic cells of body, particularly in the liver, spleen, and bone marrow. In Gaucher disease, the degradation stops at the level of glucocerebroside, which accumulate in the phagocyte. Gaucher cell. So cells become enlarged with some reaching up to diameter of 100 micrometer because of the accumulation of the distended lysosomes and acquire a pathognomonic cytoplasmic appearance characterized as a wrinkled tissue paper appearance. So this is the pathognomonic of Gaucher disease. Gaucher disease is caused not just by burden of storage material but also by activation of the macrophages. High level of the macrophage derived cytokines such as interleukin 1, 6 and tumor necrosis factors are found in affected tissue. In type 1 disease, it is also called as chronic non-neuropathic form, account for 99% of the cases of Gaucher disease. So here there is no neurologic sign symptoms in affected individual. This disease is characterized by clinical or radiographic bone involvement like osteopenia, focal lytic lesion and osteonecrosis, patient present with hepatosplenomegaly and the absence of CNS involvement. The spleen often enlarged to massive proportion, filling the entire abdomen. Gaucher cells are found in liver, spleen, lymph node and bone marrow. So type 1, it is a non-neuropathic form. Type 2 and 3, these are characterized by neurological sign symptoms. So remember, type 2 and 3 are neurologic symptoms. In type 2, these manifestations appear during infancy and more severe, whereas in type 3 they emerge later and are milder. So type 2 occurs in early age group, type 3 on later age group. Type 2 is more severe and type 3 is less severe. Liver and spleen also involved, and clinical features in type 1 and 3 are dominated by neurological disturbances including convulsion and progressive mental deterioration. So this figure shows Gaucher cell. So this is a special stain, right stain. You can see the crumpled tissue paper like appearance of cytoplasm. You can see the cell size compared to other cell. So size is reached up to 100 micrometer. Here this HNE stain. So here this is the Gaucher cell, small nucleus and enlarged cytoplasm. So this is the smear of bone marrow. Here you can see the Gaucher disease. So typical Gaucher cells are here. You can see the cytoplasm distended, vacuolated. Second is Niemann-Pick disease. Niemann-Pick disease is characterized by primary deficiency of acid sphingomyelinase and the resultant accumulation of sphingomyelin. It has a three type, type A, B and C. In type A, it is characterized by severe deficiency of sphingomyelinase, the breakdown of sphingomyelin into ceramide and phosphorylcholine is impaired, and excess sphingomyelin accumulated in the phagocytic cells and in the neurons. The macrophages become stuffed with droplet of particles of complex lipid, imparting a fine vacuolation or foaminess into the cytoplasm. So here you can see liver biopsy of Niemann-Pick disease. Here you can see the hepatocytes distended and it shows fine vacuolization or foaminess of cytoplasm. Here you can see in all these cells. Niemann-Pick disease. So all these cells have distended and vacuolated cytoplasm. On electron microscopy, it shows vacuoles of engorged secondary lysosome that often contain membranous cytoplasmic bodies resembling concentric laminated myelin figures, sometimes called zebra body. Here you can see concentric myelin. Here you can see and compare with this zebra bodies. Alternate dark and light bands are found on electron microscopy. The organ most severely affected are spleen, liver, bone marrow, lymph node and lung. The splenic enlargement may be streaking. CNS, including the spinal cord and ganglia, is also involved. The affected neurons are enlarged and vacuolated as a result of storage of lipids. This variant manifests itself in infancy with massive visceromegaly and severe neurologic deterioration, and death usually occurs within first 3 years of life. Type B variant, it have organomegaly but no neurologic manifestation. So remember in type 2 there is no neurological manifestation. Estimation of the sphingomyelinase activity in the leukocyte or cultured fibroblast can be used for diagnosis of suspected cases as well as the detection of carriers. Antenatal diagnosis is possibly by enzyme assay or DNA probe analysis. So these are the method of investigation. Type C disease. Type C is quite distinct at the biochemical and molecular level and is more common than type A and B combined. Mutations are two related genes. NPC1 and NPC2 can give rise to disorder, with NPC1 being responsible for majority of cases. Unlike most other lysosomal storage diseases, NPC is due to primary defect in lipid transport. Affected cells accumulate cholesterol as well as gangliosides such as GM1 and GM2. Both NPC1 and NPC2 are involved in the transport of free cholesterol from lysosome to cytoplasm. NPC is clinically heterogeneous. The most common form manifests in childhood and is marked by ataxia, vertical supranuclear gaze palsy, dystonia, dysarthria, and psychomotor regression. Mucopolysaccharidosis. Deficiency of enzyme involved in degradation of mucopolysaccharides. There is accumulation of the mucopolysaccharide in macrophage and endothelial cells. Several clinical measures of MPS classified numerically from MPS 1 to MPS 7. The mucopolysaccharides that accumulated within the tissue include dermatan sulfate, heparan sulfate, keratan sulfate, and chondroitin sulfate. Clinical features of MPS. It manifests in infancy and early childhood and involve multiple organ and tissue like connective tissue, liver, spleen, bone marrow, lymph node, kidney, heart, and brain. Patients have hepatosplenomegaly, skeletal deformities, lesion of heart, subendothelial arterial deposit in coronary artery. So these are the found in patient of MPS. Myocardial infarction and cardiac decompensations are important cause of death. Most cases are associated with poor facial feature, clouding of cornea, joint stiffness, and mental retardation. Tay-Sachs disease. So it is a autosomal recessive disease. It is a gangliosidosis and characterized by accumulation of gangliosides principally in the brain as a result of deficiency of catabolic lysosomal enzyme. Depending on the ganglioside involved, these disorders are subclassified into GM1 and GM2 categories. Tay-Sachs disease is by far the most common of all gangliosidosis, and it is characterized by mutation of consequent deficiency of beta subunit of enzyme hexosaminidase A, which is necessary for degradation of the GM2. So, in absence of this enzyme, it results into Tay-Sachs disease. More than 100 mutations have been described. Most affect protein folding or intracellular transport. The brain is principally affected because it is the most commonly involved ganglioside metabolism. The storage of GM2 occurs within neuron, axon cylinder of nerve, and glial cells throughout the CNS. The affected cells appear swollen and foamy. So here you can see one affected cells with enlarged cytoplasm and swelling of cytoplasm. On electron microscopy, it reveals walled configuration within lysosome composed of onion skin layer of the membrane. So here you can see the concentric lamination. These pathologic changes are found throughout the CNS, peripheral nerve, and autonomic nervous system. The retina usually involved. The pallor produced by swollen ganglion cells in the peripheral retina result in concentric contrasting cherry red spot in the relatively unaffected central macula. So here you can see the cherry red spot in cornea. The most common acute infantile variant of Tay-Sachs disease infant appears normal at birth, but motor weakness begins at 3 to 6 months of age, followed by neurologic impairment, onset of blindness, and progressive more severe neurologic dysfunction, and death usually occurs within 2 to 3 years of onset. Glycogen storage disease or glycogenosis. It is an inherited deficiency of any one of the enzymes involved in glycogen synthesis or degradation, can result in excessive accumulation of glycogen or some abnormal form of glycogen in various tissues. Based on specific enzyme deficiency, glycogen storage diseases are divided or classified into 8 subtypes, type 1 to type 8. So this is a diagram which shows glycogen metabolism, and this glycogen, which with help of various enzymes in his pathway, ultimately converted into lactase. Deficiency of any one of these enzymes can lead to glycogen storage disorder. So these are the examples of various subtype of glycogen storage disease with associated enzyme deficiency and organs involved. On the basis of pathophysiologic findings, they are divided into 3 categories: hepatic, myopathic, and miscellaneous type. In hepatic type, the enzyme deficient is glucose 6-phosphatase. In myopathic form, enzyme deficient is muscle phosphorylase, and in miscellaneous type, deficiency of acid maltase and lysosomal glucosidase. So these are the various enzyme deficiency which lead to either hepatic, myopathic, or miscellaneous type of glycogen storage diseases. Hepatic type, liver contains several enzymes that synthesize glycogen for storage and also break it into free glucose. Deficiency of the hepatic enzyme involved in glycogen metabolism is associated with 2 major clinical effects. First is enlargement of liver due to storage of glycogen, and second is hypoglycemia due to failure of glucose production. So here hepatomegaly occurs and there is a hypoglycemia due to failure of glucose production. Von Georg disease resulting from lack of glucose 6-phosphatase is most important example of the hepatic form of glycogenosis. Second, myopathic type, most form of the glycogen storage disease which affect the muscle. When enzymes that are involved in glycolysis are deficient, glycogen storage disease occurs in muscle. There is a associated muscle weakness due to impaired energy production. Typically, myopathic form of the glycogen storage disease are marked by muscle cramp after exercise and myoglobinuria. Myocardial disease resulting from a deficiency of muscle phosphorylase and is the prototype of myopathic glycogenosis. Type 2 glycogenosis, it is also known as a Pompe's disease, and it is caused by deficiency of lysosomal acid maltase and associated with deposition of the glycogen in every organ, but cardiomegaly is most prominent feature. Most affected patients die within 2 years of the onset of cardiorespiratory failure. Therapy with the missing enzyme can reverse cardiac muscle damage and mostly increase the longevity. So this is the diagram which shows glycogen metabolism. So in normal situation there is no hepatomegaly, but in case of hepatic type of glycogen storage disease, here you can see the hepatomegaly. So this is the again microscopic figure. So in left side it is a normal cardiac muscles. In right side you can see the vacuolated cytoplasm in cardiac myocyte in glycogen storage disease due to accumulation of the glycogen within the cytoplasm. So this is all about various storage disorder of infancy and childhood. Thank you very much.